landmarks are posterior superior iliac spine and the ischial tuberosity. 6 centimeters away from posterior superior iliac spine is the point of entry. Here the patient lies in a lateral position with the leg to be blocked on the upper side. The posterior superior iliac spine is marked, the greater trochanter is marked a 0.6 centimeters away. After adequate local anesthetic injection is given, a 10 centimeter insulated needle pierces exactly at right angles to the gluteal muscles, and we will start getting contractions of the hamstring. As well, there is a plantar flexion indicating me that the tibial nerve has been blocked. A parasacral approach is the importance is that it not only blocks the sciatic nerve but also the sacral plexus. Here, as the plexus is in vicinity, a small amount of drug is required, and it's more important approach for patients with amputated limb, where we cannot see whether there is plantar flexion or dorsiflexion. These are the references. Now, a transgluteal approach is performed at the level of the sciatic nerve when it is just down the piriformis muscle. So this is at this level. Now the patient lies here. The landmarks are like this. The greater trochanter is marked. The posterior superior iliac spine is marked. It's joined. The point exactly in center is taken under right angles to this is a line drawn. 4 centimeters away from the perpendicular line is the point of the entry. This can be reconfirmed by a line joining from the greater trochanter to sacral hiatus is the point of entry. Now this is the position. This is also called a Sims position. Here the patient's limb to be blocked lies on the upper side with the head, with the body slightly tilted forwards. The posterior superior iliac spine is marked. The greater trochanter is marked. The line is joined. The midpoint is chosen. A 0.5 centimeters away from the midpoint on the perpendicular line is the entry point of the needle. A 10 centimeters insulated needle is usually required. Positive end attached to the patient, negative end to the exploring needle, and here is a 10 centimeters insulated needle. After adequate local anesthetic is very important because these are all deep blocks, and the patient, it may be very much painful to the patient. Adequate sedation is must, and then a needle is directed perpendicular to all the planes of the back of the gluteus maximus, and we will see starting the twitches of gluteus maximus indicating that the tract is right, and we will get hamstring muscle twitch and the plantar flexion. If we slightly move the needle from the site, we may start getting the twitches of dorsiflexion, that is the common peroneal nerve. Giving a multiple stimulation technique is a better choice in lower extremity blocks. These are the references for transgluteal approach. The anterior approach, it's a little bit deep block. The sciatic nerve lies posteriorly, but we can block it from the anterior side. So these are the landmarks. The inguinal crease is marked, which is a natural fold. A line is drawn perpendicular to this line 4 centimeters away at exactly at right angles starting from the femoral artery. These are the landmarks. A patient lies in a supine position in this, and a small pillow is given under the leg so that the patient is comfortable. Then after drawing these landmarks 4 centimeters away from a line parallel to the second line, that is natural fold, the femoral artery is marked. After adequate local anesthetic in the direction of the needle, a 15 centimeters insulated needle is required in almost all the patients to perform this block because it's quite a deep block. Adequate sedation to all lower extremity blocks is must. A positive end is attached to the patient and the negative end to the exploring needle, which is 15 centimeters long insulated needle. The needle is directed exactly perpendicular to all the planes of the thigh. Now here sometimes or most of the times we hit the femur, that is the middle trochanter. So the manipulation which is required now, I am hitting the femur, is just to rotate the leg medially so that the needle slips on the sciatic nerve and we get dorsiflexion and plantar flexion. The moment the needle is there, we will start getting dorsiflexion, and just little bit middle movement will give us a contraction of the tibial nerve. Important points only for those patients who cannot be positioned laterally or in a prone position. It's a very deep block. Continuous catheter for pain management is not possible as the nerve lies exactly at right angles to the needle entry. These are the references. Now the popliteal block, which is most commonly performed by all. The popliteal block is performed at the level of about 7 to 8 centimeters above the bifurcation. Here are the landmarks. Here a line is drawn at the intercondylar level. That is a popliteal line. A line exactly perpendicular to this line is the second line, which is drawn 7 centimeters away from this line is the point of entry, which lies in between the semimembranosus, semitendinosus and biceps femoris muscle. Here the patient lies in a prone position with the legs off the table to differentiate between the, to appreciate the twitches. And the patient, after giving local anesthetic, a 5 centimeters needle is sufficient as it's a superficial block. After adequate local anesthetic agent, a 5 centimeters insulated needle which is attached to the patient, we will immediately get the twitches of dorsiflexion and plantar flexion. Coming to the popliteal block of lateral approach, I have just introduced this slide just to demonstrate that the femoral vessels at the site of popliteal region are quite away from the nerve. So the chances of puncturing the vessel is very less with this. In this, the patient lies in a lateral position with marking the vastus lateralis and biceps femoris muscle. And here the positive point is that the patient lies in a supine position with a marking of about 7 centimeters away from the popliteal groove towards the cephal end is the point of entry of the needle. Here the patient lies in a supine position with a slight flexion of the leg will indicate the biceps femoris and the vastus lateralis muscle, and here is the groove where we perform the block about 7 centimeters at the cephal end from this point of entry. Now 10 centimeters insulated needle is taken. It first hits the femur. Yes, now the needle is redirected about 30 to 40 degrees downwards in search of the sciatic nerve, and the moment we slip the femur, we can get the twitches of the sciatic nerve as dorsiflexion or plantar flexion. So this is a dorsiflexion, the common peroneal is stimulated, and then plantar flexion, where we stimulate the tibial nerve. It's performed in supine position, which is comfortable to the patient. These are the easy block to perform. Minimum 25 to 20 ml of the drug is required. We usually use ropivacaine and bupivacaine in a dose of 20 ml of 0.5%. The onset time may be 15 to 30 minutes.